recognized in the 80s prior to prior to this MMWR, which was 45 years ago, just this month, 45 years ago, which demonstrated a CDC response to the detection of 26 gay men who between the ages of 26 and 51 who were identified to having Kaposi sarcoma. And previously, this again was a uncommonly reported malignancy. But over a period of 30 months, they identified 26 patients, and they recognized that something was going on. This again was before we knew about HIV, and definitely before we knew about the pathogen that could cause or potentially link to Kaposi sarcoma. When they looked at data from the New York University Cancer Registry, looking at patients who had documented KS between roughly the 10-year interval prior to this, they didn't identify any cases from one hospital, and over a 30-year time period or 20-year time period identified only 3 cases. And so they knew that something was amiss. And these CDC investigators appropriately hypothesized that it was an activation of an oncogenic virus during periods of immunosuppression, which may result in the development of Kaposi sarcoma. And again, this was really quite remarkable that they identified or made this hypothesis, which we would later find out in 1993 what that virus is. And from the early start of the HIV pandemic, we recognized that there were certain cancers that were more common among patients living with HIV, and it was related to the depth of immunosuppression. And so early on in the epidemic, the CDC and others defined AIDS-defining cancers and non-AIDS-defining cancers. The AIDS-defining cancers were Kaposi sarcoma, non-Hodgkin lymphoma, and cervical cancer. And these 3 are all associated with another cancer-causing virus. And the non-AIDS defining cancers were anal cancer, liver cancer, Hodgkin lymphoma, and lung cancer. And with the exception of lung cancer, those other 3 are also caused or associated with another cancer-causing virus. The AIDS-defining cancers are typically identified more commonly soon after an HIV diagnosis, whereas the non-AIDS defining cancers are more common 5+ years after a diagnosis of HIV. And the risk compared to someone without HIV also informed these decisions to make this designation in part. With Kaposi sarcoma, the risk is 500x of someone living with HIV versus someone without HIV. For non-Hodgkin lymphoma, systemic non-Hodgkin lymphoma, it was 12x. And for CNS lymphoma, it was 150x. And there are certain types of non-Hodgkin lymphoma where the risk is even a systemic lymphoma, that the risk is even much greater than 12x. And those include primary fusion lymphomas and plasmablastic lymphoma, and cervical cancer, where the risk is 3x. For the non-AIDS defining cancers, some of these cancers, the risk is actually as high as the AIDS defining cancers, specifically anal cancer, where the risk is 20x compared to someone without HIV. For liver cancer, it's 3x. For Hodgkin lymphoma, it's 8x. And for lung cancer, it's 2x. Given the rapid improvement provided by antiretroviral therapy and increasing global access to antiretroviral therapy, we thankfully have seen the AIDS-defining cancers decline. And you can see the inflection point in this decline really parallels the easy access or easier access of antiretroviral therapy in the 90s, and that decline has continued to the present. Whereas the non-AIDS defining cancers has been relatively stable, but now the incidence of the non-AIDS defining cancers is higher than the incidence of the AIDS-defining cancers. And so this is data that shows the standard incidence ratio of the various AIDS-defining and non-AIDS-defining malignancies. And you can see from the first column or the second column with the standard incidence ratio that it's listed as living with HIV versus meeting criteria for AIDS through another defining illness. And for each of the AIDS-defining malignancies, whether it's systemic non-Hodgkin lymphoma, KS, or cervical cancer, the standard incidence ratio is, as seen on the left side, 10 to 15 times for systemic lymphoma, 250 for CNS lymphoma, 1,300 for KS, and 2.9 for cervical cancer. But you can see it's dramatically elevated among patients with AIDS. This demonstrates the depth of immunosuppression is also a common culprit for the AIDS-defining malignancies. Whereas for the non-AIDS defining malignancies, there is a slight increase in the standard incidence ratios between patients living with HIV versus those who meet the criteria for AIDS. But the difference in incidence ratio is not as dramatic as it is for the AIDS defining malignancies. And so now we know that the cause of Kaposi sarcoma and other lymphoproliferative diseases is the Kaposi sarcoma herpes virus, or HHV-8. This is a double-stranded DNA gamma herpes virus, as you know, and like other gamma herpes viruses, can live in both a latent phase, in which only a few associated genes are expressed, or a lytic phase, where nearly every viral gene is expressed. This results in higher viral loads as well as the production of various cytokines. This virus infects a range of cell types, including B cells, plasmablasts, and endothelial cells. And its geographic variation is the geographic variation of the various diseases is related to the seroprevalence of KSHV. The highest prevalence is in sub-Saharan Africa. And so this is just a diagram of the different types of lymphoproliferative diseases or manifestations, systemic manifestations of that KSHV is involved with. So primary effusion lymphoma, which can be an extracavitary primary effusion lymphoma or standard primary effusion lymphoma. KSHV diffuse large B cell, not otherwise specified. KSHV multicentral Castleman's disease, Kaposi sarcoma, as well as the KSHV inflammatory cytokine syndrome, or KICS. We'll talk about a few of these, most of these entities subsequently, with most attention paid to KS. And so KS is globally the most common malignancy in people living with HIV. It manifests as cutaneous, pulmonary, lymph node, and GI involvement. And the symptoms associated with KS typically reflect the site of involvement. So patients can present with dyspnea, cough, hemoptysis, weight loss, or abdominal pain if, in particular, the pulmonary, or if there's pulmonary or GI involvement. And there is wide geographic variation with regard to the incidence and prevalence of KSHV, and we can see that the global burden of KSHV is really primarily centered in sub-Saharan Africa, but present globally. And this, not surprisingly, also parallels the mortality secondary to KS as well, where it is again the burden is in sub-Saharan Africa. And this, for really this reason, is how the collaboration between the Fred Hutch and the Uganda Cancer Institute was first initiated by infectious disease colleagues, Larry Corey, Julie McElrath, Corey Casper, Christine Johnson, Warren Phipps, infectious disease investigators who were interested in particular in this relationship between uh, KSHV and Kaposi sarcoma and the burden it played in various sub-Saharan African countries, including Uganda. There are four major epidemiological forms of KS. The classic KS is seen more commonly among older men of Mediterranean or Eastern European origin. It was how this entity was first described. It typically has a more indolent course. There's the AIDS-associated Kaposi sarcoma, and this occurs with advanced HIV. This can be aggressive and often disseminated, including visceral involvement. Endemic African KS, which occurs in sub-Saharan Africa and may affect younger individuals. And then iatrogenic KS, which occurs in patients receiving immunosuppression roughly 2 to 8 months post initiation of immunosuppression, and does also have a male to female, a male predominance, 2 to 3 to 1. These are images of KS. The picture on the left really illustrates the woody edema that you can sometimes see with KS. In addition to the cutaneous manifestations, when there's lymphatic involvement in particular, it can cause woody edema. The oropharyngeal mass on the upper right slide is characteristic of KS, and it really is why we really need to do a thorough oropharyngeal exam for patients to look for KS. And then the slide on the lower right is a picture of cutaneous KS, multiple lesions on the back. Pathologically, this is a characteristic slide of the tissue involved. It has these spindle cells that you can see, these the elongated, darker blue, purplish slides, which with even blood extravasation in the vascular spaces. And there are a host of oncogenic and angiogenic proteins involved. LANA1 is a common one, the latency-associated nuclear antigen, viral IL-6, and a viral G protein coupled receptor. And these promote angiogenesis, endothelial proliferation, and the inhibition of apoptosis. And these oncogenic and angiogenic proteins have long been known, or not, been known to underlie the pathogenesis of KS. This was a article from 2013, which demonstrated that a deficiency in a protein OX40 could, in this particular article, described an inherited deficiency of OX40, which underlied the development of classic KS in childhood. Now, this was particularly important because just earlier this year, there was a medication that was used for a variety of conditions, including atopic dermatitis and asthma, which was a OX40 inhibitor. And it was shown there was signals which demonstrated a development of KS and another malignancy with among patients who received this agent. And so it actually was withdrawn from the market. So well, not withdrawn, they ended the late stage development of this. And it had priorly met its primary endpoints of effectiveness in these conditions, but given the concerns about this deficiency and the subsequent development of malignancy, including KS, it was the drug was no longer supported. Now, this is data from the Journal of Clinical Oncology, where they looked at a particular approach on how to treat patients with the KS, but it also showed us what the progression-free survival for patients with KS were. And we'll go over the staging subsequently, but for early stage disease, the long-term survival is around 80%, the progression-free survival. So quite high, relatively high. And this is with the use of the modern antiretrovirals. But there is a decrement when we have T1 or more advanced KS in terms of survival. And so when we think about any cancer or most conditions, not just cancer, the first thing we think about, obviously, is how we can prevent the development of the condition, in this case, the Kaposi sarcoma. And this is a study that you all are more familiar with than me, but it was the START study where they randomized patients living with HIV who were treatment naive with antiretroviral and a CD4 count greater than 500 to two groups, either the early antiretroviral group where they received antiretroviral therapy upon randomization, or the deferred group who did not receive the antiretroviral therapy until the CD4 count decreased to 350 or the patient met criteria for AIDS. And there was equipoise at the time regarding the approach to antiretroviral therapy and the timing of initiation. So in this START study, they enrolled patients from all over the world, from Africa, Asia, Australia, Europe, North America, and South America. Relatively young age, 36 was the median age, and approximately 25% were female. And the median time since the HIV diagnosis was about a year, and the median CD4 count in both groups was 651. And so if we look at the x-axis is time by months and the y-axis is the mean CD4 count, we can see that although the mean CD4 count at initiation was 650 and similar, those who received the immediate initiation obviously increased their CD4 count quite dramatically compared to the folks whose initiation of therapy was deferred. But relevant to this talk, it also demonstrated that there was a decrease in the number of patients who subsequently developed both KS and malignant lymphomas. For KS, there were 11 patients who developed KS in the deferred initiation group versus only one in the group that received immediate initiation of therapy, which met statistical significance. For lymphoma, it was 10 and 3 respectively, not quite statistically significant, but likely based on numbers. In any case, we know that this is now the standard of care. And so the most important thing we can do to prevent KS among people living with HIV is to start antiretroviral therapy. The staging for KS is a little is not the typical staging system that we use for most cancers or any other cancer. It incorporates both the tumor itself, the immune system, as well as the presence or absence of systemic disease. And so T0 Kaposi sarcoma is that which is confined to the skin or lymph nodes and potentially minimal oral disease, whereas T1 disease is tumor-associated edema, like that picture we showed of the woody edema, ulceration, extensive oral KS, GI KS, or KS in organs other than the lymph nodes would be T1 disease. The CD4 count, if it's greater than 150, we consider that IO, versus if it's less than 150, we consider it I1. And then the systemic disease both incorporates historic past medical history of opportunistic infections, including thrush. If there's no history, that would be S0, and if there is history, there is S1. The absence of B symptoms. The B symptoms, as you know, are fevers, night sweats, or weight loss. And then a functional status that's greater than 70%. So generally that they are up and active more than half of the working day. In KS, we also don't always treat patients in addition to the treatment that they would receive from antiretroviral therapy. And this is for a couple of reasons. One is even our therapies, and we'll talk about the various therapies, our therapies currently are not curative for KS. They can control the disease can regress, but because our therapies don't eradicate the virus, we don't cure this disease. And so we have to be particularly thoughtful about when to give therapies because the therapies, as we'll discuss, can be pretty toxic. And so what are the indications for treatment? So if there's extensive skin involvement, if there's the woody edema, if there's systemic visceral involvement, so the hemoptysis, dyspnea, GI bleeding, or if there is immunoconstitution inflammatory syndrome. These would be the general indications to treat. These are indications for systemic treatment. Sometimes we do local therapy for lesser involvement, including lesser cutaneous involvement. We're also seeing that, so this was a report from the CDC, again, earlier this year, in March of this year, where they reflected on KS-associated herpes virus infection and complications among solid organ transplant recipients. And this is in part because this rise, they have seen a rise, and we've actually seen a patient here recently who was a status post lung transplant. And it's just something that there's not routine screening of donors as of today. And so it is something that we should think about and I know our colleagues that you all who are on the solid organ transplant unit here at the University of Washington think about. But a timely report. Okay, so what are the potential treatment options that we have? So antiretroviral therapy, which again can have a response within months, and 20 to 80% of patients may have a response just to antiretroviral therapy. There is this iris that we know about so patients can have a tumor exacerbation, and this the things that can help predict whether that would happen would be both a high HIV viral load as well as a high KSHV viral load. The common therapies and the first line therapy as of July 2026 remains cytotoxic chemotherapy, which the most common one that we use here is liposomal doxorubicin. And if that's contraindicated, our next option is paclitaxel. These are still the first line therapies for the treatment of Kaposi sarcoma. We do increasingly use other agents now in the second line, and we'll talk about one of them, immunomodulatory agent pomalidomide, as well as immunotherapy, which has really changed the landscape of how we treat cancer in general. I mentioned briefly that the treatment is really, we have to determine whether it is limited disease or more advanced disease. And so if a patient were to have limited cutaneous disease, our treatment options really are dictated on whether it's causing symptoms or is cosmetically bothersome. And then we potentially can use local therapy, including intralesional chemotherapy, which is what we typically do here in the Madison Clinic with Dr. Colvin in dermatology. You can use radiation therapy with modest effect. Sometimes we do use systemic therapy, or always thinking about a potential clinical trial. And so this would be a sort of how we think about it for patients with limited cutaneous disease, who are symptomatic. If a patient is asymptomatic, we typically would just observe. For advanced disease, whether it's advanced cutaneous or pharyngeal disease, visceral disease, or potentially nodal disease, we first decide whether the patient is eligible for systemic therapy. And that really is really just primarily a function of a functional status of the patient, as well as if there's any contraindication to the specific chemotherapies. And again, it is the first line remains, as of now, systemic cytotoxic chemotherapy. And so there are reasons why that may be a contraindication for certain patients. And those would include potentially heart failure or if there are issues with bone marrow suppression. And so given the various cells that are involved in Kaposi sarcoma, the plasma cells and its upregulation, there has been thought of can we do things to impede the development of KS, at least slow down its production. And so they studied a drug called pomalidomide. And so it affects various cells, the monocytes, the plasma cells, T cells, as well as our osteoclasts. And so it has been used, given this, the range of cells that it does target, it has been used in a variety of conditions. Most commonly, we use this agent for plasma cell disorders like multiple myeloma. And this was a study about 10 years ago where they looked at this agent, pomalidomide, for patients with and without HIV who had symptomatic KS. And if they had at least 5 cutaneous lesions, if they were living with HIV, they were on antiretroviral therapy with a controlled viral load. They had parameters for their blood counts, including their neutrophil count for hemoglobin and platelets, as well as kidney function. And there was no CD4 count criterion. And these trial participants were were given 5 milligrams of pomalidomide, 3 out of 4 weeks. So 21 days and then 7 days off, and they repeated that. And so most of these patients were around 50 years. Total, they were 50 years old. The people living with HIV were slightly younger at 49 versus 61 years old. Importantly, you can see that many of these patients were heavily pre-treated. So 86% of the patients had prior therapy. That most commonly was cytotoxic chemotherapy, but also radiation therapy. And 2/3 also, or 1/3 also received local therapy. In these plots, we can see the blue are individuals living with HIV. The gold are those without HIV. And you can see on the left side of this is the change in the number of nodular lesions, and the table on the graph on the right is the change in the total number of lesions in total. And you can see for both, there was a dramatic decrease in the change from baseline with this agent. And again, the majority of these patients had advanced disease, T1 disease, as we described, or they were previously treated. And so it is now approved, pomalidomide, in the second line of therapy, and it's something we regularly do. Now, importantly, pomalidomide is an agent that is given orally, and so it may have particular utility in the treatment of KS in sub-Saharan Africa, where infusional or IV therapies are more challenging to administer. And so there is a trial right now looking at the role of pomalidomide monotherapy among HIV-positive individuals with KS in sub-Saharan Africa through the AIDS Malignancy Consortium. A very recent trial included the use of this agent, abemaciclib, in KS. Abemaciclib is an agent that is approved for the treatment of breast cancer. And it is in the next slide, I'll talk about it, but this study was a phase 1/2 study in participants with KS. And so the abemaciclib is what's called a CDK4/6 inhibitor. Again, it is used in patients with breast cancer. There are 3 different agents, palbociclib, ribociclib, and abemaciclib. It inhibits cyclin D1, which is, among other things, responsible for the propagation and development of KS. We can see in this map the increase in the immune cell surface markers. The CDK4/6 inhibitors increase the immune cell surface markers, which may put a block on the viral-mediated immune evasion. That was demonstrated from colleagues at the NCI some years ago. As well as we know that the KSHV infected B cells are dependent on cyclin D1. And so the thought was that if we can inhibit that, that may lead to a regression of KS. And so these investigators presented this data last year at the American Society of Clinical Oncology annual meeting, where they assessed the safety and tolerability of this agent. We actually had a patient on this trial as well, who we sent to the NIH for this study. There were some eligibility criteria, as you can see, and again, patients had to have measurable skin disease. The eligibility criteria and the primary and secondary objectives were similar to the prior study on um, on pomalidomide. The same group of or the same center at the NCI administered these studies. They the investigators assessed response by the AIDS Clinical Trial Group, or ACTG, response criteria, which incorporates both the total number of lesions, the nodular lesions, as well as sort of the dimensions or the sum of the areas of 5 target lesions. And just like most KS studies, they assess the complete response, where there's a resolution of all KS lesions, a partial response, which is greater than 50% decrease, progressive disease, or stable disease. And this is pretty standard. The study schema was they had a dose level, and they had a 3x3 dose escalation design. The phase, and then they went to the phase 2 component of the therapy, and they split them among patients who had received prior KS therapy or no prior KS therapy, and they evaluated a total of 31 patients. In this study, just like prior, we can see the stage 2, 0, there was only 18% of the patients. The majority of patients were T1 disease. And a third of those with T1 disease had visceral involvement, GI or pulmonary KS. The median duration of ART use was 2 years, a CD4 count of 427 with a low viral load. And among all participants, the response rate was 84%. Now, the majority of these response rates are partial response, which is a win for us. So a very dramatic partial response. This was seen both among patients who had received prior KS therapy and those who did not, actually even had a higher response rate, and the median time to response was 2.5 months. These are some of the candidate lesions that we're seeing, both in the hard palate, the skin, and ocular involvement, and really very dramatic responses among the patients who received it and who did respond. And so this is not yet it's not yet published. The authors of this have submitted this for publication. It's under review right now, and I expect this will change the treatment landscape as well. And again, we know that immunotherapy has really changed the landscape of how we treat a host of malignancies. This is taking advantage of our immune system and the effect of our immune system in targeting the tumor cells and taking off the brakes of the response through the suppression of T cell activation and reactivating that. And so there's some thought that immunotherapy in particular may be particularly helpful for KS and other virally associated malignancies, both because the chronic T cell stimulation from both the HIV and in this case KSHV leads to an upregulation of PD-1 as well as a T cell exhaustion. And the thought is that the PD-1 inhibitors may improve immune surveillance and cause unexhaustion of the T cells, and potentially is less toxic. We know from a host of malignancies that the response rate to PD-1 inhibition and other immunotherapies is really dependent on the tumor mutational burden. On this slide, you can see a host of different malignancies, and the malignancies on the right side of this screen with melanoma, squamous cell lung, bladder cancer, those are tumors with a very high mutational burden, and the ones with a very high response rate. Now, interestingly, um, when we think of KS, it actually doesn't have so high of a tumor mutational burden. And this is actually data from, that data is from Warren Phipps, who showed that there's not such high mutational burden among KS. The MCPY is the Merkel cell polyomavirus, which is the virus that is responsible for a fraction of patients who develop Merkel cell carcinoma. Merkel cell carcinoma is also caused by ultraviolet radiation. And Merkel cell carcinoma that is virus negative, the ones that are caused by ultraviolet radiation, do have a high uh, mutational burden versus compared to the virus positive Merkel cell carcinoma. But interestingly, in the studies that have been done for Merkel cell, both the Merkel cell polyomavirus positive as well as negative Merkel cell carcinoma did respond to PD-1 inhibition. And so this was a multi-site study looking at pembrolizumab among patients with KS. And they received this agent 200 milligrams every 3 weeks for up to 35 weeks, 35 cycles rather. The age was comparable to other studies, the previous studies that we described, as well as the distribution of tumor stage, with 81% of participants having T1 disease. The majority of participants did have prior systemic therapy. The number of prior systemic therapies ranged from 1 to 12, and a third of patients had prior radiation therapy. And it was relatively safe. So 2/3 of patients, sorry, 2/3 of patients did have one adverse event, but these were most were grade 1 or 2, in which the treatment was continued. A third experienced immune-mediated adverse events, and importantly, one participant died due to a KSHV-associated polyclonal B-cell proliferation. So we do want to be thoughtful about who are candidates to receive these medications. But the response to therapy was quite good, and in many patients, quite durable. And so it is something we also think about, but again, there are some limitations to its use. The overall response rate was 62%, but among those who received this agent as the first line therapy, it was 87.5%, where it was about it was 52% among patients who had received other therapies prior. Now, again, overall response rate does include partial response, and in fact, the majority of these responses were partial. 2/3 actually were partial response, 28% were stable disease, and 10% had progressive disease, with a median time to respond around 3 months. In this curve, the progression-free survival is quite high. The 1 year is just under 70%. And this agent really, or these agents, types of agents, really provided a high rate of a durable KS response. And again, these are patients who ART itself wasn't sufficient. And the overall response rate, again, and the progression-free survival of over 2 years, it compares favorably to standard cytotoxic chemotherapies, doxorubicin and paclitaxel. Okay, a few minutes on KSHV multicentral Castleman disease. This is due to immune dysregulation secondary to elevations in various cytokines. It causes constitutional symptoms. It can cause lymphadenopathy and splenomegaly, and it can cause bone marrow suppression through via anemia, thrombocytopenia, and elevated inflammatory markers. The diagnosis of multicentric Castleman disease really is determined by a pathologic findings. There's plasmablastic findings on a lymph node biopsy, which reveals a nodal expansion, and this is a polyclonal disease. The plasmablasts are positive for KSHV, but the nodal architecture is generally preserved, and this is in contrast to lymphoma, where the nodal architecture would be disturbed. The treatment for multicentric Castleman's disease includes rituximab, which targets our CD20 positive B cells to sort of slow down the inflammatory milieu, antiretroviral therapy, sometimes plus minus chemotherapy, and that really is somewhat dictated if there's also concomitant Kaposi sarcoma. There's a potential role, though data aren't so great, on the use of antiviral therapy, as well as increasing evidence of the role of IL-6 directed therapy. IL-6 directed therapy is used and approved in idiopathic Castleman's disease. And so the overall survival for KS is not as good as for overall survival for multicentric Castleman's disease is not as high as it is for KS, but it is better than the next entity, which we'll talk about, which is the KIC syndrome or KSHV inflammatory cytokine syndrome. Again, this is similar to Castleman's disease. It's an immune dysregulation secondary to various cytokines. It can cause constitutional symptoms. Splenomegaly and lymphadenopathy are less common in KICs, unlike Castleman's disease, but the anemia, thrombocytopenia, and elevated inflammatory markers are common to both. The distinction is that there cannot be Castleman's disease, so you do need a biopsy to exclude the possibility of Castleman's disease. And these inflammatory markers are quite similar to what we see in Castleman's disease for the KIC syndrome. We do generally get a KSHV, which is the viral load via PCR amplifications, which amplify the ORF73 gene. This is not an FDA-approved test, but it is a test that we run here at the University of Washington on Thursdays, and it does give us a clue regarding these conditions. We can, in addition, obtain, in addition to the blood, we can obtain KSHV viral loads on biopsy, bone marrow, or other fluids. And again, it's done here at the University of Washington. And we also typically obtain an IL-6 level in these patients, and this is a test that's also done at the University of Washington and is run daily. It gives us a sense also of the inflammatory milieu. The treatment and there's not so much data, but the treatment of the cytokine release syndrome is chemotherapy and rituximab with antiretroviral therapy, and similar to the multicentric Castleman's disease, there's some limited data on the role of antiviral therapy and IL-6 therapy. I just wanted to briefly mention that the treatment for KS secondary to transplant recipients is slightly different for any of these conditions, and we do want to sort of do some adjustment to their immunosuppression. And so sometimes if they're on an agent like tacrolimus, we may switch to sirolimus as well. But the Kick syndrome, unlike Castleman's, the overall survival is quite poor. There's not so much data, but the small prospective studies that we do have demonstrate a median overall survival of just over 1 year. And then I'm not going to talk about KS iris just in the interest of time, but you all know more about this than I do, and I'll just spend one slide or two slides on the last entity, primary effusion lymphoma, which is an aggressive B-cell lymphoma associated with advanced immunosuppression. It typically presents as effusions in body cavities, pleural effusions, peritoneal effusions, pericardial effusions. I have a patient at the Madison Clinic who developed tamponade because of primary effusion lymphoma. They oftentimes do not have any detectable solid tumor masses, though there is a variant that is nodal. This entity, primary effusion lymphoma, is often CD20 negative, and so the role of rituximab, which is limited for primary effusion lymphoma. And primary effusion lymphoma is also frequently co-infected with the Epstein-Barr virus, though it's not required for its pathogenesis. The treatment is ART and systemic chemotherapy. Again, because most of these are CD20 negative, rituximab is not effective generally, and we do try to drain the effusions. So thank you all for your time. I'm happy to answer any questions either now or feel free to email me or reach out. Thank you.
Great. Thank you so much, Manoj, for a great talk and update. I would invite the audience to put any comments and questions in the Q&A box, and we'll review those. Manoj, do you want to stop sharing your screen? Other
Yes.
things on your desktop are coming up.
Yeah.
Great. And you've got lots of clapping going on. So while we're waiting for some questions to come in, and we've just got about 6 minutes, I wonder if you could say more. You mentioned with the abemaciclib trial that you thought that would, once published and may soon really change the approach to KS. Do you think that will become, can you say more about how you think that will change?
So right now, for a lot of cancer therapies, the treatments really are dictated in part by it's very sort of algorithmic, and I showed some of those algorithms that are defined by the National Comprehensive Cancer Network, or NCCN, which we are a part of. And the treatment of KS is informed by those algorithms. And so right now, the first line is cytotoxic chemotherapies, and then there's a variety of second line. I think once it gets approved, it will go to the second line therapy initially, and that's where pomalidomide is, that's where PD-1 inhibitors are, and that's where this will be initially. And then I could see in the future this coming to the first line as well.
Interesting. Thank you. All right, we've got a question from Sujit Govindan, who says the HIV guidelines state the risk of KS-IRIS may be increased when ART is started without concurrent chemo. We had a case where a patient was diagnosed with visceral KS but not started on ART as they were waiting to transfer to our center to initiate chemotherapy. This delayed his ART start by several days. How do you define concurrent? Meaning, what time interval can we start ART before chemo is started in cases of visceral or systemic KS?
I mean, you can start them together, and so because the treatment for KS-IRIS is actually chemotherapy as well, and so you could start them concurrently. The challenge sometimes is whether or not they are if there are other parameters that would preclude therapy. And so in the past, it was thought that we had to be a little bit careful of starting chemotherapy as we start antiretroviral therapy because of overlapping toxicities and not identifying which agent or agents are responsible for the toxicities, including bone marrow suppression. And now we're a little bit more liberal with its use in the right setting. But KS, I will say KS, for most patients with KS, there's not an urgency to start chemotherapy. We have a little time to sort of assess what's going on and the need for treatment. The responses to therapy are not so to KS-directed therapy are not so immediate, and so we do have a little time to be thoughtful about the approach. One thing I didn't mention is that there is this concern about steroids and the initiation of steroids that can cause an exacerbation of KS. And so we are thoughtful about the use of steroids. It's not a absolute contraindication. But it is something we think about given the role of steroids in a variety of roles for patients.
Great. Thank you. No other questions. I guess, Manoj, I might ask just from the clinical perspective, since you are seeing almost all of the patients with KS, I imagine. Could you talk a bit about just roughly how often do we use chemotherapy? It seems to me like it's the small minority of cases, but I'm not sure that's correct.
So we use it quite a bit for patients if they meet the initial criteria. Fortunately, we are seeing, thankfully, less and less KS here because of widespread access and use of antiretroviral therapy, but it still remains the frontline therapy. Now, most of the patients that I see now at the Madison Clinic, they're they're now presenting with KS after, in the past, having received chemotherapy. And so once it's progressed, really the first line therapy is that you give chemotherapy. Depending on the duration of response, you either can give that first agent again if it was a prolonged duration, or you can go to the second cytotoxic chemotherapy, or you can give one of these agents. But many of my patients that I see now who I'm treating for KS, they've already had chemotherapy and probably don't want chemotherapy again, even if it could be effective. I mean, chemotherapy can be toxic. In those studies, actually, there were patients who died of febrile neutropenia from KS, from the cytotoxic chemotherapeutic. So we would prefer using something else if we can.
Wonderful. Great. Well, we are at time. Thank you so much, Manoj, for a really wonderful talk. And thank you, Carrie, for your help with the conference today. And thank you all so much for joining. Have a wonderful rest of your day.
Thank you
Take
all.
care.
Bye.
Bye-bye.